digital diagnostics and how empowering patients in Africa with reach of doctors here in America can actually help improve technology, medical technology in America, and help improve healthcare overall. We're going to look at what is the state of mobile health technology here in America today. What are the HIPAA regulations and how do they limit technological growth? What a pilot program in Africa can do to help expand this, and help deal with this problem we have, and what kind of mobile technology can help bridge the assessment, the recruitment, and the attainment of patients, and what are the roles of organizations, be it business, schools, networks, in order to get this done. First of all, let's talk about mHealth, mobile healthcare. It's a brand new field. It really just started. A lot of people, a lot of doctors talk about telemedicine, and they're well aware of this. It's been around since telephones. But now we're dealing with mobile health technology. We're talking about smartphones. The first iPhone app came out in summer of 2008. A lot of people, can't even remember what they were doing before the apps, right? But before summer of 2008, no one knew what an app was. By 2010, when the droids came, the droids really people got used to them. People didn't know what you said or meant when you said app. Unless you said iPhone app, they didn't know what you meant. This mobile technology can help reshape this landscape of healthcare. And before that, we didn't have a basis for this. So you have this new phone, you have this touch screen, you have these apps that can do something. Okay, now what can we do with this? So the scale of thought and the where to go with those thoughts just really started around 2010. Since 2010, we've had over 9,000 patents in mobile healthcare. Most of these are just people thinking and just making patents. Instead of building something with them, they're just anticipating. And we can do broad things with this. We can, the sky's the limit on where mobile health technology can go. And it's not, we're talking about, for example, you have Blue Cross Blue Shield medical insurance. You're in the middle of Nebraska. Someone in Boston has Blue Cross Blue Shield medical insurance. You're paying the same thing, but you do not have the same access to the same kind of doctor. What this technology can do is diminish those gaps. So we're going to look at what people are comfortable with today when it comes to what they're willing to do with their mobile technology when it comes to healthcare. Most of mobile health apps out there are fitness apps, health and fitness apps. They were created mainly because there's less regulation around these issues. And so, these lack of regulation allowed them to expand, on this. My best friend in college, for example, built this company called TidTrack. TidTrack helps you track everything, and he, as of last week, closed a deal with AT&T, where I guess when you're on your phone, you can tell if you're jogging now. I haven't talked to the guy in 15 years, but like mine, feel like 52% of customers are interested in buying health trackers, like TidTrack, which is close to deal with Samsung and AT&T. We're talking about wearable tracks and wearable devices. This is what people are comfortably used to accepting right now in terms of mobile healthcare. people always ask me, so can you wear it? No, this is not the same thing, but I'm glad you at least understand where this technology is for you, so let's go. 86% of patients conduct a health-related search before going to the hospital. We've all been there. You have a cough, you go on WebMD, and you think you have pneumonia, right? Now WebMD's convinced you have pneumonia, and you get to your doctor, and you're like, all the signs of pneumonia, I think I have pneumonia. But, so we're taking steps beyond that, and we're starting self-diagnosis, and you go online, you check Facebook, you check social media, you check so many things before you go to the hospital nowadays, before you just go to the hospital. CBW, that's where we got the information. This is going to continue to grow. So we just talked about the base of where we are now, what we're comfortable with. So what's really going on in this? When you pick up your tablet and you're about to enter the world of mobile healthcare. And what's going on and so we have 85% of patients do not know the name of their physician or anything about their physician. They just go in. Between 30 to 60% of medication dosages are, 30 to 60% miss their dosages, and also you have, when it comes to clinical trials, most clinical trials are rarely completed. You have people not interested in keep going back to the hospital and back to the hospital for the same trial. With mobile healthcare, you can just be at home and conduct the trials from home.
What do you mean by clinical trial? Like a medication trial, or
continue, or
like for a pharmaceutical clinical trial?
There we go.
Okay.
Right? And they're usually conducted in the hospital. You stay in the hospital and do all that stuff. Now you can just have the person at home, and you spend less money managing those folks who don't finish the trial, because you're losing money every time you don't have a completed trial. And this is where the money is, right? Supposedly, mobile healthcare is going to hit up to 200, billions and billions of dollars coming up, right? We're not talking about the money specifically. Now we're talking about what we can do as an industry, as a medical industry, and where we can go to improve lives with technology. So these numbers say 93% of physicians believe mobile health apps can improve patients' health outcome. I've been on the blogs. That's not the number I personally got, but I'll just read this out because they did the information. So what can we do if it's fully functional? You can have education wellness apps on the same app. You can have procedural explainer. Doctor, why am I doing this? It could be on the app. You can have bedside care items on the app, medication reminders. So we can actually have fully serviceable mobile health care in a way where the hospital can feel like it's right there. You don't have to get into your car to get there. So where we're going next. So why is this not moving forward? Why don't we already have it going on? We have over 9,000 patents in this field. Why are we still struggling? Why are there only 1 or 2 folks at Harvard building this? It's just a lot of regulation on this. We're talking about patient health records, electronic medical records being heavily regulated to the point that you can't even conduct trials to see if your product works well enough to send them back to the hospital and say, let's go from here. Where we should be with the electronic medical records is, since we have hospitals that are fully digitized, we should at the minimum have digitized hospitals where the doctors now can have the information outside the hospitals and the patients can have their own information. We have something close to that in some areas, but it's not fully mobile yet. So people are afraid to to face these kind of penalties. And even if you're not being, if you're building this kind of stuff, you're then being investigated, even if you haven't done anything wrong. And you're paying for lawyers, you're paying legal fees, and if you don't have money for that. So when I first started building this, I would talk to a lawyer, because I needed to get research on this stuff. I wasn't at the time, really deep into this stuff. And the lawyers would run away from me, because they didn't have time for this. They didn't have time for what they needed to research to get my questions, to answer my questions. So I had to learn on my own. You have civil penalties that are out the rules that you have. Those are the criminal penalties. No. Criminal penalties are scary as well, and these sources are the Human Health Services. So, what can we do? Where are we with electronic health records? I know doctors who, run their own clinics who are still using paper records. There's one doctor who I invited here. He said, "Wait, are you talking about electronic medical records?" I'm like, "Yeah, well, this is mobile though. This is the next stage." He's like, "I've had my clinic since 1972, and I still record my records the same way. Thank you." I'm like, "Okay, well, you could." He's like, "The government makes me pay through Obamacare a certain fine every year, and I pay the fine, and I'm going to pay it next year." And I'm not coming, by the way. Well, thank you. All right, I didn't need to, we're not changing weight. But we're growing with the electronic medical records, I guess due to Obamacare and due to penalties. Some folks are using it more. So here we have Brigham and Women's that still uses paper records. One of the largest hospitals in Boston. Unfortunately, I was born there, by the way. Critical.
That's about to change. They're implementing Epic.
Yeah, okay, implement Epic. Okay, so thank you for introducing that to the conversation. Epic, for example, and Epic's competitors, right, are looking into going to this next phase as well. But it's been so hard for them to even get into their actual market that, it's just opened a huge arena for young entrepreneurs to build mobile healthcare. Maybe Epic will later on join us in this. So what it basically says is Americans are ready for electronic medical records. Where we're going after that is we want to integrate medical records, EMRs, with mobile healthcare. This is what is currently not taking place at large. We have maybe 3 or 4 companies doing this. And we think there should be more, but still, folks are scared of regulation, folks will see the bang for the buck. Silicon Valley, for example, is where you have all these entrepreneurs who could do this, but the fact is there's more money in video games. Okay? And as long as there's more money in video games, okay, those who have the talent to digitize and make all this stuff happen are really going to stick to what they do best.
There's more money and there's faster money. So we tried to recruit in Silicon Valley to do something like this, which is a longer term investment.
Yep.
And the number one question was how many months until I become a millionaire? We're like, no.
Exactly. Months.
Months. Exactly.
And I lived there, and let me tell you something. I know these guys, right?
Yeah.
And I've literally seen and hung out with guys who had no furniture, living on peanut butter sandwiches, and I come back to Boston, I go back to visit them, and they're trying to show me the difference.
Yeah.
And it's very entertaining. Video games. All they did was build a video game, and their life changed drastically. What will it take to take this next step? It'll take quite a bit, but there is a map to getting this done. We'll have to have funders from across sectors. We'll need variety of partners. We'll need a pilot that's focused, a pilot plan that's focused that can show how this works and the quality of this. We'll need to have centers where we can access quality care. We have those already, connected to a platform that's grassroots based. And we're going to have some kind of way to manage data mining and data sharing. And that sharing obviously has to be secure, okay? I mean, and you have to have a digital scope for the impact that it can make. So there are several organizations that we've been in contact with. We're currently in this one here, and where it makes sense that this is needed. It makes sense this is needed. But once again, we're just focused on the impact. And we believe here that with the quality of people we have here, we can make an impact, we can show the impact. And then we can maybe compete with the video game producers.
So what kind of feedback are you getting back regarding funding from these organizations? Are they, well, if you put it together, we'll fund it, or are they not too interested?
When you say these organizations, let me go
Well,
back.
some of these, whatever ones
Okay.
that you've gotten further with.
Everyone says they're interested. Okay, everyone wants to see more, right? The last year, 2014, we've had a huge, the fastest growing industry, according to Google, has been the mobile health industry. So I would say 2 years ago, it was impossible getting one's attention. Now it's the easiest thing to do, right? People want to see what's hot. They want to know, have a look, and move on. Okay? So we've had to be proactive in looking at, let's say, different kinds of grants that might deal with medical devices, different kinds of pharmaceutical firms that have funds for, small production of, X, Y. So a lot of these folks are right here in, the Microsoft, the Google areas, the MIT area, that quad. Has been very helpful. We've met with a lot of these folks, and we know the competition. It's a small world, folks who are doing this kind of stuff. So it's been positive. It's been positive, but people talk more than they do. Right. So this is what we built. Okay, we built a way where you could have a virtual doctor's appointment directly on your cell phone or tablet, where the patient sees one thing on one side, the doctor sees another thing on the other side, and it's all managed by a back-end server that is secure. Patient comes in, fills in the questionnaire, the information goes back, there's videos and there's voice recording. The voice is live, the video is recorded. With more money and all that stuff, we'll have live stream, video stream. But at least the doctor sees what the patient has. And then it comes back here. And I'll show a demonstration later. So, as I said, this is where we were in 2008. It was just one of our advisors at the time was in the United Nations, and he brought up the idea for mHealth in the United Nations. We've passed these, we've been dealing with the regulations, and now we're expected that mHealth apps will integrate to people's daily routines, and to a certain extent, many of the health and fitness apps have. The future of this is what we see, okay, and this is what we intend to build. A virtual mHealth hub that attaches other mobile health apps all to one hub. So we're not necessarily competing, but we do it better. No, we want every patient to have as much access as possible. So we want to have a hub where there's regional healthcare, your closest healthcare provider, and you can basically deal with any doctor using artificial intelligence anywhere in the world that has a specific area of specialization that deals with your illness at the point of a click. That's where we intend to go. How are we going to get there? All this technical stuff. So we will We're starting with Africa. Then we're going to Asia and Latin America. We have a partner here who's also a non-resident fellow. He's currently in Spain. But one of the great things about being a fellow here, you get to meet people like that. You get to meet a guy who has 1,000 employees and makes $100 million a year. And so I want to do that too. Right? So his company already has networks all these places. All we have to do is build the first kind of product that works, and then spread it to his partners' firms, and we'll have them around there. So, what are we doing? What is this? What is this thing that we're going to do now that's going to be the nucleus of a pilot that's going to move everything forward? We're going into Nigeria. The Federal Republic of Nigeria announced a few years ago that they want to save 1 million lives in Nigeria using information communication technology. Currently, they don't have that technology, so we say, let's propose. We have an actual strategy that we could enter Nigeria with, and we're working with doctors on the ground to make this happen right now. What and how can we effectively show that this product works? By showing how it saves lives and showing that it can help save lives. All right. By doing that, we're focusing on one target illness, or two target illnesses, which is infants and maternal mortality. The average woman in Nigeria giving birth, what's the average? I would say less than 37% of the women giving birth in Nigeria give birth in front of a doctor. We believe this is one of the reasons why infant mortality rate is so high. Right after I built the prototype for this, the gentleman who I have my background, I went to high school in Nigeria. My dad was an international businessman, and so we had, sometimes we'd be there. So the gentleman who helped raise his wife died giving birth right after I built the prototype, and it was. It just made more sense to me, hit home a little bit more. So we want to give this product to 10,000 pregnant women, and also implement electronically this with hospitals. So it's kind of e-care and care and health. And so we have a large city like Lagos that has 12 million people. So if we install the to come hospitals in Lagos that can reach up to 1 million people, and then we can go. I'll show you an example after this, from little local town to local town, local village, and educate what we have the healthcare professionals there. We can now show how we can get into the rural areas. And into the rural areas that connect to the major cities, we'll now have a graph of some of this stuff to bring back here. And after that, we'll have a post-execution clinical review with a team of doctors that are watching this now. Start smart, think big, scale rapidly. That's all business talk. So how are we sure this will happen? I mean, people don't understand. In Africa, they use their mobile phones. They were on WhatsApp before I knew what WhatsApp was. I remember going to Nigeria in 2003, and people were texting, and I never texted before. And they're just texting, and they're like, "Wait, text me." It's like, I don't have a text. I don't, So they're much more advanced in mobile technology than we know. There are 100 million mobile phone lines in Nigeria alone. In a population of 160 million. So 2 out of 3 people have a cell phone. So how are we going to do it? There are 4,000 private health clinics and hospitals in Nigeria. Compared to America, there are 4,000 urgent care hospitals in America. Very competitive as an example of what can happen. So we have teaching hospitals, and obviously we're going to use that kind of example to show how to educate this in the long run. So where are we? 2003, we're in the pre-discovery, and discovery, 2013. This is where we were in 2014, and this is where we are now, entering the pilot stage. So as of next month, I'll be heading to Nigeria to begin. You asked the question about, how supportive are folks and these companies. We're going to need folks outside normal areas of capital. So we're looking actually for charitable funds to come to make this happen, this initial part. So if you know anyone in the Gates Foundation, feel free to call them. All right, so we found a solution, we found a need, we're approaching this. This is our scaled plan, our governance plan, our strategy, the operations, how it will work, and we've dealt with the vendors and the technology that we have. So that was what you just saw was the first 8 to 10 weeks, and then we have 3 to 6 months milestones, and what will happen, what we expect after a year. We've defined our roles, and we're approaching this very meticulously. My technology team, they're with this group, Impiger Mobile. They're based out of Texas and India. Very soon I'll tell you exactly how this whole thing works, with a list and everything completely. I'll give you that diagram in a second. And this is the team of doctors who initially came to help figure this out. So what I did was, after Dr. Keith Black suggested this should be done, I ran with it, and I started calling doctors around the country because it's a very popular doctor, right? So I said, hey, Dr. Keith Black thinks it's a good idea, could you talk to me? So I got about 20 doctors on a call at the same time, asked them how would they use this if they wanted to do it, how would they use this? They all broke down what this could do maybe for them, how they could use it, and then I put that into a code, contacted my tech folks, and then we had the prototype. We've looked at but many of the other providers, and most of these folks are, once again, in health and fitness. 15% of these applications are primarily designed for healthcare professionals. What are we talking about? Okay. Most of people still need to have someone intermediary. Like we're talking about the WebMDs of the world. You look at it, if you just read WebMD and then you go and you self-diagnose and self-treat, that's not what we're really trying to do here. We're not trying to do that. So we want something that you still need to kind of go through a healthcare professional, help you out with this, and so that's how we're building this movement. Okay, so we've assessed and got a kind of a list of how to get as many doctors into this network as possible. All right, we have the list: 27,000 members of Doctors Without Borders. What we're like is Welcome Global Family Doctors, where we have up to 300,000 doctors on one email list. Okay. So we're going to start small here with very qualified minds, create a nucleus with the quad here in Boston, and then expand all into one system with secure. We want to focus on security as well. That's what I just told you about the Nigerian pilot. Okay, so this is what the tech guys want to know. Okay. Anyone know about Snapchat? Snapchat. So only one person? Hands of Snapchat. 1, 2.
Heard of it, but I
Okay.
don't know anything
You don't use it. Snapchat is now worth $10 billion. Okay? I was in a conversation yesterday at, I was geeking it out, okay, with some tech guys, and Say, Zuckerberg, she was foolish for buying WhatsApp for 19 billion. WhatsApp will never make 19 billion. Snapchat has proven how it's worth $10 billion. I'm thinking, Snapchat? We just $10 billion? So there is money in data and data alone via mobile services. What we intend to do is create quality first. Then we'll compete with the different ways of making money via mobile marketing. Now, what are we talking about? Substance, as I said. What are the problems we have? What are the problems we have in the industry? The recruitment strategy, how to recruit patients, how do we keep recruiting patients? I was having a conversation with folks at Pfizer, and they said they need to find ways to get this new generation of millennials who think they're too healthy to get health insurance or get Blue Cross Blue Shield, and how they think they're too healthy. Then they're trying to as well manage these the older generation that they think go to the hospital too much when they're not really that sick. Okay, so what kind of data can we get to help recruit, retain, and assess? And that's what we're looking for here. What kind of new drugs will be needed in which regions, when, and why? This is the kind of information you can get by having people with their cell phones react and act on these topics. Which kinds of illnesses, specifically, what kind of drugs will they need? Will they be injectable? Will they be oral? That kind of information is also the kind of data mining information we will be providing. And when you do, how do all of these, how does the medical device get to all of these topics? And how do we assess, how do we measure them, how do we have some kind of format into keeping this information where it's manageable and easy to assess and deal. This is what we're producing. And when you do, where do they go? Where do you deal with your expenditure when you understand that information, if you are a healthcare firm? So, through the pilot by looking at maybe our first 100 pregnant women, we'll be looking for more than just the infant mortality issue. We'll be looking for all the health issues that they're dealing with while trying to help them give birth. Okay? We're showing that we can actually attempt to save lives while improving our clinical analysis on all sorts of things. And just more ways to assess. And when we get this data, there's a lot we can do with it. All right, let me switch from here and give you So, this is our lead doctor, Dr. Iyabo, educated here in America, back in Nigeria, showing how this product can be used with local healthcare workers. Okay, the aim is to get to as many of these local healthcare facilities as possible, educate as many people, come back for feedback, and connect them to whatever is the major hospital in the region. From the confused faces in the room, it's going to take more than one sit down. But we want these folks to be connected. These are hardworking people who do not have access to good treatment. But places like Nigeria, we have a lot of educated, well-to-do doctors. One doctor once told me, who works here in America, who wanted to go back to Nigeria, said, what do you do when you're conducting surgery and the electricity goes off? Do you feel like a great doctor then? right? So there are all these other issues as well that, that these doctors have to deal with, like Dr. Iyabo. And so partnering with the country to help us, help them improve their healthcare system can actually help us understand our technology better. If there's any point that I'm trying to make today, that is the point I'm making here. And what is she showing them? And what are they so confused in looking at? Is that large or small? It's not small. Excuse me. I'm going to have to open my email to give you guys the prototype example. All right, so this is the back end technology. We just showed you what the patient sees and the doctor sees on the front end. So what we, after all of this assessment we go through, what we're going to do is then add the artificial intelligence necessary to make this dynamic. As I said, all this does now is allow a doctor to see a patient, view the patient. Not in the States here, we're not doing it in the States yet because of HIPAA regulations, but in Nigeria we can see the patient's medical records, okay, and apply whatever he wants to. What we intend to go further in is once we kind of get the norm of that, and once we have all these doctors all aligned, we can now have applied artificial intelligence that can tell the app itself which doctor to lead the patient. So the virtual medical visit is like this. Come in, welcome message. You know, it's just like, it serves like that first nurse you see that's asking you some, you know, basic questions, your height, your ID number, you know, your medical ID number, we're gonna need that. We're gonna look at your records. You know, your age, height, male, female, you know, those kind of things, right? And then it's submitted to the doctor the same way the nurse submits information after that first visit. The doctor comes, handles what needs to handle. This is what you got. Here's you, subscribe to your original. So it's going to manage your patient records. It's going to be supported with saved information, so you can go back and look at what you look like later on and see how It's going to save your messages and information so you know exactly what happened between you and the doctor. It's going to be a summary, and there also will be a 24-hour nurse hotline you can speak with in case you need a nurse from wherever you are in the world. That's what it looks like. Log in, patient side. The healthcare professional adds the patient's information. Patient details, the doctor gets the message. So the pilot program is, you know, if we do it we could do it in 3 weeks, 6 weeks, I showed you earlier, 3 month, and initially for iPads, but it'll be multi-platform when it's done. And once again, Integer is our technological partner. They have over 500 years of man hours when it comes to IT projects that they've built for these kind of folks. So where are we with this? And so when we're done with that, when we're done with doing this in Africa, we'll go to other emerging areas like India. Go back to slide. That's our initial medical advisor. It's me. That's Dr. Black on seeing Larry King Live. That's him on cover of Time magazine. That's our medical implementation director. This is her actual visit to a hospital. We just showed you a visit to some local health facility. This is at a hospital in a abandoned village. We're dealing with women and their children specifically first. Go from there. And we're doing this with the intention of medical breakthroughs. This is a teaching hospital. We'll be going into teaching hospitals. And then we'll go into major hospitals. And then we'll come back here. Thank you very much.